Hi, everybody. Welcome to Chapter 2 of Abnormal Psychology. I hope that week 1 of this class was enlightening for you and that you maybe learned some new information already in the first chapter. And so we're just going to continue to build on that. And what we're going to be talking about today is diagnosis and treatment of mental health disorders. So starting out, we're going to talk about sort of the different roles of treatment, and really starting out by talking about, here you see on this side, the psychologist is defined as the healthcare professional offering psychological services, and the client is the person seeking psychological services. So it doesn't always have to be a psychologist. Keep that in mind. And also good to remember that client can also be interchanged with patient in some instances. I prefer the use of client when I'm referring to people that I'm working with in a therapeutic situation, because I feel like client kind of comes off as not pathologizing them as much as patient. And I think it makes them kind of more of an active participant, like thinking of a client as somebody that is, seeks out your services and then kind of works collaboratively with you, instead of a patient who is receiving those services, maybe without that emphasis on collaboration. So the client are the people in treatment who collaborate with the people who treat them. And here we go, patient carries with it the connotation of a passive rather than active participant. I think especially when you think of like a patient in a hospital, that person is receiving medical care and they're sort of not having much to do with it. It's been more left up to the experts, up to the doctors. And with treatment of mental health issues, it's really important to really hear what your client is saying their experience is, because that's how we help them and that's how we diagnose them. It's not the same objective information as like treating somebody with a broken arm, obviously. Our clients need to tell us what's going on with them, and also, really be able to advocate for themselves as far as the therapeutic benefits and what's working and what's not as you move along through the process. So next we have the clinician. Here we go. Here's a little more definitions of different forms that the clinician can take. So the clinician just refers to the person providing treatment. Here you see that some types are psychiatrists, and these are medical doctors, and they do their, I guess, residency, it would be, in psychiatry. So when a medical doctor is choosing their specialty, these people go through med school, and then when they hit that point, they choose psychiatry. So they are trained medical doctors. Then you also have a clinical psychologist, who is a mental health professional with training in the behavioral sciences, who provides direct service to clients. Interesting little side note that you might have seen in your textbook about clinical psychologists is that they are not allowed to administer medication, with the exception of 3 states as of 2015, those being Louisiana, Illinois, and New Mexico. And this is interesting. Also, you think about this in Wyoming, nurse practitioners can do a psychiatric track and become psychiatric nurse practitioners, and they can be prescribing psychotropic medications. That's not true in all states, and really is more common in areas that are more rural and don't have as many professionals working. So there's a real need for more people to be able to prescribe, so that there's enough therapeutic support in these more rural areas. So 2 types of doctorates in psychology. One is a Doctor of Philosophy, which is a PhD, and the other is a Doctor of Psychology, which is a PhD. The Doctor of Philosophy is typically awarded for completing graduate training in a research-based program, and the PhDs must also complete an internship and at least 1 year of supervised postdoctoral training. The Doctor of Psychology is the degree that professional schools of psychology award and typically involves less training and research. They also have to complete an internship. Basically, everybody who has any kind of degree, master's level and up, has to have done some form of practicum and internship where they're supervised in their training. So I'm sorry, this always happens to me. Okay, here we go. I want to go back here for a minute because I want to talk about also people with master's degrees. That's the level that I'm at. I'm a licensed professional counselor, and I have a master's in science. So master's of science, master of arts, and master in social work. These things all allow you to practice independently also on that level. And of course, people who are practicing at this level cannot prescribe any medication. Then there's another really important tier to mental health providers, and these people might not have master's degrees, but their work is really important. And these people can be occupational therapists, recreational therapists, and counselors who work in institutions, agencies, schools, and homes. I want to add in there another really important role. Certification can be people who are licensed addiction counselors who don't have a master's degree but have a bachelor's, and they can provide really, really great and important work for people with addictions. So it's kind of the rundown of different levels of clinicians. And I think, sorry, going back that one more time, just remembering that really the difference, big difference between psychiatrists and psychologists is that psychiatrists are, again, are actually medical doctors, and psychologists have a different doctorate degree. So that's just an important little note to make. Okay, so now we're going to talk about the actual diagnostic process. And of course, in order to diagnose any condition, medical or mental health wise, there needs to be kind of a recognized manual and a streamlined way of doing this so that it's a little more consistent, right? So here we have a little talk about reliability and validity. Now, I'm pretty sure that everybody has gone over this before if you have taken general psychology when we talked about research. But reliability is the degree to which clinicians provide diagnoses consistently across individuals who have a particular set of symptoms. So looking at, okay, these people have these same symptoms, making sure that these people who are presenting with these symptoms are basically fitting into this diagnosis. So across the board, if this person went to see one clinician, they would probably have the same diagnosis as another clinician. Of course, when we're talking about mental health, that's not 100% always the case because it's a subjective diagnosing a mental health condition is more subjective, like I was talking about before, than a lot of these medical disorders, right? So again, going back to that thinking of if somebody has a broken arm, that's very objective and very diagnosable. If a client is naming off symptoms that they're experiencing in their head that we can't see on the outside, that interpretation could come across differently to different providers. And that is why it's so important that we have some kind of manual to follow to help sort through that. Then we also, validity is the extent to which a test, diagnosis, or rating accurately and distinctly characterizes a person's psychological status. So of course that just means that you want the diagnosis to make sense for what the person is experiencing. Otherwise it would be really silly. Another note about diagnosing and reliability and validity is that while it can be difficult at times to to sort through what the right and correct diagnosis for somebody for a mental health disorder is. It can be really important, especially when we're talking about helping the client to understand what they're going through, as well as on the more practical side, insurance companies require that there's a diagnosis that's made. So when somebody comes to counseling for an issue, the clinician has to make a diagnosis in order to justify to the insurance company why this person needs treatment. So there's a couple different levels there. So we're going to talk a little bit now about the DSM, which is the Diagnostic and Statistical Manual of Mental Disorders. In the United States, this is what we use as far as classifying symptoms into labels and disorders. This book is published by the American Psychiatric Association that contains standard terms and definitions of psychological disorders. The most recent DSM is the DSM-5, and this was published in 2013. There was a big shift that happened that's important to know about between the DSM-5 and the DSM-4. The DSM-4, you'll see here, had a system of diagnosis that relied on axes. Okay, so you would have different axes for different disorders, as well as different stressors that contribute to disorders. What happened when the DSM-5 came out is it got rid of the axis, and what we do now is we diagnose, the first diagnosis that we'll write down is the most prevalent. So if somebody comes to treatment and they're really suffering from a substance use disorder and also an anxiety disorder, for instance, the way that we would diagnose that now in the DSM criteria is whichever one was causing more distress at that time. So if that person's really struggling with the substance use and the anxiety is contributing to it, we would diagnose that person with the substance use disorder at the top, and then the next disorder that we would write would be the anxiety disorder. And then if there were more, it would just continue on in descending level of distress. Another interesting thing about the DSM-5 that changed is it can be downloaded, can be used on Apple and Android devices in order to make it more accessible as we're moving more and more towards technology-based electronic health records and just using more technology in our lives in general. It's divided into 22 chapters, and each includes sets of relating disorders. So if you look through a DSM, you'll see that there's a section for anxiety disorders. There's a section for mood disorders, which include things like major depressive disorder and bipolar. There's a trauma disorder. There's a substance use disorder section. So all of these different sections is kind of how it breaks down. Important to note that most mental health professionals outside the United States and Canada use, instead of the DSM-5, they use the World Health Organization's diagnostic system. And this is the International Classification of Diseases, which is the ICD. The most recent ICD revision, it's now ICD-10, and these are codes that are label specific disorders. These are also the codes when you're a clinician and you're billing insurance. Those are the codes that you use. So the DSM-5 has its own set of codes, and then the ICD-10 are different numbers. So that's just a little side note. Oftentimes when you're writing out a diagnosis, you'll use both. So you'll use the DSM diagnosis and then maybe in parentheses right next to it the ICD diagnosis, and then you'll actually write out in words whatever it is. So that's about that as far as that stuff goes. Oh, see, look at all these slides. Other important thing, Z codes are used by clinicians to indicate the presence of psychosocial and environmental problems. So if there's problems going on that really help explain why the person is experiencing what they're experiencing, those will be found in the Z codes. So somebody comes to you and they're experiencing a great deal of anxiety. Probably you would want to include a Z code if they were facing something like problems in their relationship with their spouse, because that could definitely contribute to their anxiety. And I think those two just help sort of paint a clearer and more inclusive picture of your client so that it's not just the one, diagnosis. Helps kind of understand what's going on there. So here is in your book, this is table 2.1, and this is the breakdown of disorders I was talking about, how they're categorized in the DSM-5. So you can take a look at that. And here's just some more. We'll be learning a lot more about these disorders as we go on. But just take a look at it because it's interesting to just see how they have split these disorders up. And here's an example of Z codes. And you can see, of course, change of job, sexual harassment, all of these things can definitely contribute to experiencing some feelings of, anxiety, depression, all of those things. Also, there's the World Health Organization Disability Assessment Schedule, and what that is we call it the HUDAS, and this is included as a section in the DSM-5. So this is sort of an instrument to show how functional somebody is. It is a good way to judge their psychosocial, social, and occupational functioning. So this would be probably something that would be really important if a client were to come see a clinician and that client was really struggling with daily functioning activities. This would probably be a really important assessment to do so that you could figure out, what other services might benefit them and also how these things are playing into the clinical distress that they're experiencing from their disorder. And here you go. Here's an example of that assessment. As you can see, pretty much daily living activities. And again, just sort of assessing need for extra services and also assessing sort of level of disability. So these are really interesting, and I think this goes back to what we started talking about a little bit when we started our chapter 1 about how important it is to keep in mind different cultural behaviors, right? So here's an interesting thing, culture-bound syndromes. And these are recurrent patterns of abnormal behavior or experience that are limited to specific societies or cultural areas. So they have a whole different structure of diagnosing, and it's actually quite interesting. So if you look on your page 36 of your textbook, Table 3, there's a whole list of these culture-bound syndromes, and they don't happen outside of these specific cultures or societies. So that's a pretty interesting thing to take a look at. Also, of course, that would be really important when you're thinking about a clinician who's doing any kind of international work or work with refugees, right? That there might be things going on that they're not used to seeing because of these more culture-bound syndromes. And again, just going back to that idea of the importance of cultural awareness. The ICD-10, we went over that. And also important to remember that the ICD-11, which is the next one that will be published, I think is hoping to be more of a marriage between the DSM-5 and the ICD, which will be very nice. Okay, so here we have the diagnostic process, and this is what I was talking about a little bit when I was talking about how you actually write out a diagnosis. So the principal diagnosis is the disorder that is considered to be the primary reason the individual seeks professional help. Okay, so how you get to this, how you get to the place of understanding what the principal diagnosis is for somebody, is you make sure that you do a very thorough assessment of what is happening for them, their symptoms, and all of that. Then you have a differential diagnosis. So this is the process of systematically ruling out alternative diagnoses. So a good example of this, and you'll understand this more as we move on, but a good example would be if somebody comes to you and they've just lost they're going through a divorce. They've just started going through a divorce. And they have been suddenly feeling really depressed and anxious. Now, if you didn't do a really thorough assessment and somebody just came to therapy and said that they were really struggling with depression and anxiety, it might seem like they probably had a diagnosis of a depressive disorder or an anxiety disorder. The important piece there is that there's another disorder that's called adjustment disorder, and that happens when somebody experiences sort of sudden life-changing stressful events, and it can bring on symptoms of anxiety and depression. So if you're not doing that assessment and really talking through with your clients about what's going on in their life, you could end up obviously really giving them the incorrect diagnosis, which is something that would not be ideal, especially because you want to think about, you want to be careful with sharing with clients, what kind of diagnosis fits the most, and always erring on the side of sort of moderation, right? Not jumping to the worst thing all at once. Then the other thing is comorbid, and this is when, like I said before, this situation occurs when multiple diagnostic conditions occur simultaneously. So here's a good example. Major depression and obsessive compulsive disorder exist together. Another one that's very prevalent is we see this hugely with people who have substance use disorders. So people that have substance use disorders, in my experience, almost always have a comorbid disorder of something like ADHD, anxiety, depression, bipolar, and part of what has happened in their lives and how they've found themselves really struggling with a substance use addiction is that they've been self-medicating that comorbid disorder. So this is really important to remember as we move forward. A case formulation is a clinician's analysis of the factors that might have influenced the client's current psychological status. So that's kind of what I was just talking about, that thorough assessment. The cornerstone of a great case formulation is an understanding of the client from a biopsychosocial perspective that also takes into account the client's developmental history. In some cases, family history information would also inform this part of the diagnostic process. And when I do an assessment and an intake with somebody, there's always a section where I ask about family, because I think that that's huge and can really impact somebody's mental health and also their treatment. Also, a cultural formulation. This includes the clinician's assessment of the client's degree of identification with the culture of origin. Okay, this is important because in different cultures, there's different beliefs about psychological disorders and the ways in which the culture interprets particular events, as well as how the culture supports it, are available to the client. So this is just very important to remember. Again, always the importance of cultural awareness when we're thinking about formulating these diagnoses and how we work with people. So a good example is Members of a given culture attach significant meanings to particular events. Within certain Asian cultures, an insult may provoke the condition known as amok, where a person, usually males, enters an altered state of consciousness in which he becomes violent, aggressive, and even homicidal. Without taking this background into account, the clinician may very well draw the wrong conclusions, assuming that the symptoms reflect a disturbance within the individual when they in fact reflect the playing out of a cultural influence scenario. Really important. Again, just always being aware of where someone's coming from and how that culture can influence them, as well as how, making sure that you really support clients who might come from a culture that really frowns upon psychological treatment, and really, thinks that going to therapy is a sign of weakness. Making sure that again, having that awareness of that's where they're coming from so that you can help and support them work through that. So then you move in from the assessment into actually planning the treatment. And of course, this brings us to the treatment plan, which is the outline for how therapy should take place. It's like a roadmap, and it's not set in stone. So I think of the treatment plan as being incredibly collaborative. I always ask for my clients' input into the goals. So when we're talking about the goals of treatment, it's not necessarily only me looking at a client and saying, well, this is what I think you should do, or this is what will benefit you. It's more, like I said, a conversation. So asking the client, what are your goals for therapy? How do you want to work on this? What are some things that you feel might be really beneficial? And again, just from this beginning of therapy, by doing that, you're helping the client to feel very empowered that this is really a collaborative process, and also that they're really the experts of their own lives, of course. And I also think this is important from the get-go, because the goal of therapy is to stop going to therapy. So the hope is that from the beginning of the therapeutic relationship, the client is already starting to take the initiative to make the change. And in that way, I think already starting that process of individuating themselves from their therapist, and just feeling, like I said, more empowered that they can make changes to their lives. So in your treatment plan, the goals should include immediate goals, short-term goals, and long-term goals. Good example of an immediate goal would be if somebody comes in for a first session and it's clear that they're not in a stable place and are a threat to themselves or others, or a client comes in and is expressing that they've had some suicidal ideation. So the immediate goal is to stabilize that client and make sure the client is safe. Then after the immediate goal is met, then you can start looking at short-term goals. This would be something like, move out of my apartment and find something more affordable. Write in my journal every day, those kind of things. And then long-term goals would be, where do you want to see yourself, right? Like if you could envision your life and how you want it to look, how would it be different than it is now? And what would that look like? So then the long-term goals would be, maintain lifelong sobriety, or, anything that feels like a long-term attainable goal. Of course, you want to help your clients focus on what's attainable and realistic so that they're not setting themselves up for failure or setting the expectations too high, and then again setting themselves up to feel like they haven't accomplished what they wanted. So keeping all of these goals, immediate, short-term, and long-term, these goals should all be attainable and realistic, obviously. Okay, so the next stage in planning the treatment is to determine the treatment site. So this kind of speaks to levels of care, okay? So when we're talking about levels of care, psychiatric hospitals are the highest level of care. Psychiatric hospitals are places where people who are not stable and who are a threat to themselves or others really need to be able to get the care that they need. They get a lot of attention and 24/7 supervision, and it's very restrictive as far as what these people can have, keeping in mind things like not letting them have access to anything that they could hurt somebody or themselves with, that kind of thing. And also, as far as medication goes, right? A psychiatric hospital is also really where somebody goes to be safe while doctors figure out how they can help this person be more stable so that they can go back into the community. Then you have specialized inpatient treatment centers. This would be like a residential substance use treatment center where clients go and live for, 60 to 90 days or longer, and they live there at the treatment center. And they do intensive therapy, group therapy, individual therapy, medication management, psychiatric care, all of those things are components. It can also be a behavioral health institute can be an inpatient treatment center, so it's not just substance use. But a specialized inpatient treatment center would be longer term care than a psychiatric hospital. Generally speaking, a psychiatric hospital is more for stabilization. Then we have outpatient treatment, which again, there can be different levels of this. Some people who are in treatment for substance use disorders are at a higher level of outpatient treatment, and so what that means is they will have 9 to 12 hours of treatment a week. So maybe going to 4 groups a week and doing an individual session. Or outpatient clients who are just individuals working through things when they first come to therapy in order to help them stabilize and feel like they have enough support, they might need to come twice a week. But outpatient treatment is where the person is still living in the community and coming to see the clinician. Then we have halfway houses and day treatment programs. Halfway houses are, of course, transitional places where people are coming from a higher level of care and transitioning back into the community. And day treatment programs are for people who need some structure during the day, and probably these people have been formally hospitalized, and they just need a structured program during the day. We have some of these locally, day treatment programs. Northern Inc. is a day treatment program where people can go spend the day in a structured environment with activities and supervision. Also, other treatment sites would be like school counselors, or an EAP. Sometimes at a job, they'll have a counselor come in. I just read that there's a football team, I think it's the Panthers, that now have an on-site counselor who's at the stadium, has an office there, and is available for the players. So that's pretty cool. Okay, so then as we're talking about these, the client is starting treatment, and this is also part of the treatment plan, is the modality of treatment. Okay, so this is the form in which the clinician offers psychotherapy. This goes back to individual psychotherapy, family therapy, group therapy, or milieu therapy, which is really like community-based, is the milieu. So yeah, so a treatment plan might include individual, family, and group therapy. Or the treatment plan might just include individual psychotherapy. Again, just sort of depending on where people are at. Family therapy, of course, could include couples or, parents and children, anything like that. And group therapy can be really effective and helpful for people because it's a safe environment for people to open up about things they're struggling with and not only get the support of the clinician, but also, not feel like they're so alone in their struggle and get feedback and ideas from other group members who are going through the same things and facing the same difficulties. Evidence-based treatment in therapy is very important, in psychology. Evidence-based practice is kind of just like what it sounds. So evidence-based means that it's been researched and that the outcomes are positive. So this definition is clinical decision-making that integrates the best available research evidence and clinical expertise in the context of the cultural background, preferences, and characteristics of clients. So, in other words, clinicians should be basing their treatment on state-of-the-art research findings that they adapt to the particular features of the client, taking into account the client's needs. So a good example of evidence-based practice, evidence-based technique is cognitive behavior therapy, or CBT. This is where you're helping clients really challenge negative thinking and replacing them with positive affirmations or you know, or really reality-based messages to challenge those negative thoughts. CBT in some research has been shown to be as effective as psychotropic medication for some types of depression and anxiety. Also, it's been shown to be incredibly beneficial in conjunction with psychotropic therapy. So that's a really good example of that. Again, also thinking about wanting your client to really be making progress. Also, going back to the practical side of it, when we're talking about insurance and how they work with clinicians, it's important that insurance sees that you're using evidence-based practices as well, so that they know that you're using a model that's been proven to be effective. Treatment implementation, course of treatment, the clinician's role in treatment, the client's role in treatment, and outcome of treatment. So, of course, the ideal here is that this is, again, really collaborative, and the client is really active. The also really important part of implementation of treatment is having strong rapport with clients as the clinician. So that means having established a really strong base of trust and openness, so that the client really does feel safe and supported in talking through things that they probably never have before. So creating a really safe environment for them to be able to make progress through treatment. Important to again, support clients who are coming from a background where they might feel very weak for seeking therapy. There's still, as we talked about last week, a great deal of stigma around mental health disorders and reaching out for help for these disorders. So making sure that the clinician is really supporting the client in those times. And again, always making sure that the client feels like they are able to talk to the clinician about what's working and what's not, and feeling like they have a voice in treatment, and that this is really their program, and that the most important thing, of course, is that it works well for them. Outcome of treatment, the hope is always that you and your client reach a place of mutual understanding and feeling that the client is ready to move forward and no longer is in need of the support of the clinical services. Also, that the symptoms are in remission, and remission is said to occur when the individual's symptoms no longer interfere with his or her behavior and no longer meet the criteria required for a DSM diagnosis. That's not always possible, and it's important to know that sometimes clients leave before they should. Sometimes clients leave while they still do have significant issues caused by these problems. When that happens, that's usually referred to as a client leaving AMA, or against medical advice. Of course, also important to remember how difficult it is to change. We humans, we have fantastic, brilliant minds, and we're really good at a lot of things, but change does not seem to be one of them. So keeping that in mind too, as far as what the treatment outcomes can look like. Sometimes as a clinician, you are very hopeful that your client is going to make these changes, and you can see how beneficial it would be for them to make these changes, but it's really up to them. to implement those changes and to do the hard work necessary to make that commitment and stick with it. Okay, so that's pretty much it for our Chapter 2 discussion. If you have any questions about anything that we went over or you need some more information, please always feel free to shoot me an email and I will get back to you as soon as I can and I will help you in whatever way I can. Okay? Thanks, guys. Have a great week.